Hello, and welcome to this episode of In Discussion With from Medical Update Online. Today, I'm talking to Vicky Ruszala about the recently published study of semaglutide in obese patients with heart failure. Please, could you start by introducing yourself?
So my name is Vicky Ruszala. I am a specialist cardiology pharmacist at North Bristol NHS Trust. I work as the head of the team here in pharmacy, and I'm fully part of the multidisciplinary team here and across the whole of our ICB.
Can you give us a brief overview of your role, what your current job involves?
I am first and foremost a clinical pharmacist specialist. I cover our cardiology ward, our specialist cardiology ward, and I see most of the patients. I do that most days. I also have 2 heart failure clinics a week, so I'm an independent prescriber. I have my own patient caseload that I manage. My role in that is to optimize the medications for heart failure. But I actually cover the whole of cardiology. So I'm the lead for lipids in our trust. The lipid service in Bristol is actually run at the other trust, but I'm the person that meets between the two so that we all do the same thing, and get involved in anything that the cardiologists need. So if they're looking for drug applications or new things, and looking at arrhythmias, providing advice obviously to all of my colleagues or my pharmacy colleagues and other junior doctors if they need it. So it's a specialist pharmacist role. It's not particularly exciting. It's nothing different to what many other people do. It's nothing special about it. It's what lots of people do, and I just do it here in cardiology.
Now, the STEP-HF-pEF trial has been exciting a lot of interest recently. For the non-cardiologists, please can you tell us what these mysterious letters mean and what the trial was intended to find out?
The HF-pEF is HF-pEF. That's how we refer to it in cardiology, and it means heart failure with a preserved ejection fraction. When we look at patients with heart failure, so they present with the signs and symptoms of heart failure, so breathlessness and things like that, we do a diagnostic pathway, and the gold standard for diagnosing heart failure is with an echocardiogram. And that will measure lots of different things in the heart. It will look at the valves, it will look at the atria, the ventricles, all of the bits of the heart. And one of the measurements that we are given is the ejection fraction, which is how much blood is pumped out of your left ventricle into the body. And that's called your ejection fraction. So heart failure, the traditional heart failure we think of, so it's also known as congestive and all those we don't use those terms anymore. What we use is heart failure with reduced ejection fraction. So this is an ejection fraction less than 40%. HF-pEF are people who present with the symptoms and signs of heart failure, have an ejection fraction greater than sort of 49%, so towards the normal end of the measurement. So normal normal ejection fraction is around 55 to 60%. It's not 100%, it's around there. But they may have structural abnormalities within their heart. So for example, valvular abnormalities, or they may have dilated ventricles and all kinds of bits effectively. And the bits are kind of irrelevant to everyone who isn't a cardiologist. But what it does give you is a diagnosis of a disease that is kind of really new in the game. We never really thought about HF-pEF. And when people think about heart failure, the signs and symptoms, the people they think of, the people who are filling up with fluid, who are admitted to hospital, they're your HF-refs, they're your reduced ejection fraction. But the HF-pEFs are kind of the newer in town. Now, they're not new, we've known about them for years, but we've never had anything we can really do to treat. It's always been a disease of kind of comorbidities. So having that in your head, STEP-HF-pEF was a trial that was looking at using the GLP-1 agonist semaglutide that we all associate at the moment with type 2 diabetes and most recently obesity. And it was looking at treating HF-pEF in obese patients with semaglutide to see if there would be an effect on it. So that was the remit of the trial. That was what the trial was designed to do, was to look at, does this drug work in HF-pEF?
Interesting. And what was the trial design?
So it was designed to look at obesity in HFpEF. So one of the big things is that they think that obesity may actually be a causative factor of HFpEF. It was traditionally always thought as a comorbidity. So something like so in the US, about 80% of patients with HFpEF also have obesity. And it was kind of, is it because, chicken and egg, which one kind of came first? And so this was looking at, if we treat obesity, do we treat the heart failure alongside? Semaglutide is well known in the type 2 diabetes and the obesity world for causing huge weight loss and therefore improving lots of different outcomes. So this trial was designed along the same way. It actually had a dual endpoint. So they weren't composite endpoints, it was a dual endpoint. And they were looking at improvement in quality of life. So they used a KCCQ score, which is kind of the gold standard score. And that is designed for heart failure patients, looking at improvements in quality of life, signs, symptoms, and exercise capacity. And then their other endpoint was weight loss. So they were the two endpoints side by side. They had a hierarchical secondary endpoint. So in a hierarchical endpoints, they can't test the next one until the first one's been proven. You have to stop at the point. It's a complex trial design, but effectively what it means is that unless you're proving something's working, there's no point looking around for other things.